a wonderful crowd. We are so happy that you're here with us on the last day of the conference here. My name is Carolyn McCoy. I am a program analyst at HO for the Strategic National Stockpile projects. And we wanted to welcome you, first of all, to the 6 most memorable SNS lessons you'll ever learn in 45 minutes. First of all, I'd like to thank the CDC for their support of this session, which you'll see is quite different from any other session you probably attended at the summit and maybe any other conference. And I really also would like to thank the 6 presenters we have here today who took this leap with me and to try this format here at the summit, and quite enthusiastically, actually. It's been a really great time. So what you're about to see is kind of it's known in different versions. It can be a lightning session, it can be Ignite, or a Kucha chat. And the technology community uses this format a lot to share ideas and pitches quickly. It's 5 minutes. Everybody gets 5 minutes, 20 slides, and the slides automatically rotate every 15 seconds. So you're going to see everybody either chasing or being pushed by, actually they're doing great. But the slides really kind of drive the presentation here. And so you'll see the kind of story that evolves from this format. Come on in, there's plenty of room. So we're on a quick timeline here. We've got 6 people ready to go. But just another note too, normally these sessions are done at nighttime with some adult beverages and some, appetizers over here. So I'd like to bring you mentally here with me, take a sip of your coffee, and please be receptive to the presenters this morning because this is a difficult format, and we're kind of missing some of the other aesthetics that are at these sessions. So we're recording these. They're going to be on the NHO SNS website in about a month. Ian Goldstein in the back has been our techie extraordinaire on this. And so I'd like to thank him for his help. And without further ado, I would like to introduce Michael Laird. He's the Director of Preparedness for Public Health, Seattle and King County. He's presenting Whole Community Approach to Medical Countermeasures Capability. Let's hear from Michael.
So I'm going to talk about a whole community approach to medical countermeasures. We've all been preparing for about 10 years now to receive, distribute, and dispense medicines to a large part of our population in a very short period of time. Medical countermeasures is a core capability of public health, especially local public health. We may need to be called upon to activate this capability for naturally occurring disease outbreaks like H1N1 or for bioterrorist events. However, when we started developing this capability years ago, I think we took a very government-centric approach, and we actually excluded capabilities that exist across our community. In Seattle, I know that we had really overlooked a wealth of resources, capacity, capability, and expertise that existed all around us. In fact, that expertise and that capacity is what mobilizes and dispenses medical countermeasures to our populations every single day. So we've taken a new approach. We're looking at this capability quite differently now. We now have to make sure we can make medications accessible to all who need them, wherever they happen to be in our jurisdiction, during outbreaks of all types, not just bioterrorist events, with sufficient speed to make a difference, to minimize morbidity and mortality, and in a manner that retains the trust and confidence of the public. And that is the core component we need to integrate into our work. And that is what has led Seattle towards a whole community approach to planning. Now, I think there are 3 rules that govern whole community planning. And rule number 1 is use what's there. Do not develop new capabilities or new capacity unless and until all the existing capacity you have in your community is exhausted. So where does the capacity for medical countermeasures exist in our community today? Well, in Seattle, it's in our pharmacies. It's in our large integrated health system. It's in our wholesalers and distributors. It's in our occupational health programs for large employers. Just as an example, 93% of us live within 5 miles of a pharmacy. In Seattle, pharmacies are ubiquitous. They're everywhere. This graphic shows the geographic spread and the density of pharmacies just in our area, and pharmacists are among the most highly trusted members of the public. Now, when we started developing this capability years ago, we did not really have pharmacies and wholesalers and integrated health systems in mind, and I think that was a big mistake. We are looking now at the capacity that already exists in our community, and I think we all need to start using what's there first. Rule number 2 is where there's capability, there is responsibility. Those organizations that can protect their staff and their families during all hazards, particularly disease outbreaks, should be encouraged and expected to do so. Now, this approach opens up a world of opportunity with all types of organizations to become a direct part of your local response. Federal agencies are coming on board now in a big way as closed points of dispensing. Who else could you ask in your jurisdiction? Your largest employers, your critical infrastructure agencies, universities and community colleges, large foundations. Now, some people might say, well, this sounds like you're passing the buck. And I don't think so. I don't think this is passing the buck. I think this is government recognizing and acknowledging our capabilities and our responsibilities, and those of key community partners. Those community partners are willing to step up and be part of our response. We just need to be willing to make that ask. Rule number 3 is targeted solutions for vulnerable populations require community-based expertise. Now, public pods and pharmacies can meet the needs of some of our most vulnerable residents during an outbreak, but by no means all of them. I think a whole community approach brings in the right organizations to address the needs of the homeless, homebound, immigrant and refugee population, the impoverished, groups that are traditionally marginalized in our communities and do not fit neatly within the infrastructure that we take for granted. Key organizations are essential to bring to the table to develop solutions. These are organizations like home care and home health, aging and disabilities, immigrant and refugee advocates, and local public health. That's where we fit in best, to identify the needs of these populations, to identify barriers that they may face, and to develop those targeted solutions. So the foundation of medical countermeasures in Seattle really rests within our community, not within government. I think real solutions that are going to be there when we need them most are going to be solutions that are rooted in the community, solutions that incorporate the infrastructure of the community that exists on a daily basis. I think public health should focus on what we do best every day, and we need to leverage the resources, the capacity, the expertise, and the interest that exists within our community to best meet the needs of the public. Thank you.
That was great, Michael. Thank you so much. Next, we have Justin Snare, who will be the Deputy Director of the Town of Acton Health Department in Massachusetts, presenting Can't Afford a Software Developer, Hire a Public Health Planner.
So what I'd like to relate to you is not necessarily the particulars of what I did, but why I think you could do the same thing. Developing a software product to solve a public health issue. So my particular issue was inventory management. What do we have for monsters in our inventory closet? Public health emergency preparedness response requires a lot of stuff. We have literally thousands of items used by hundreds of people located in multiple locations that need to be deployed. This stuff, the beans, the beds, the bandages, are essential to response and must be organized and tracked during storage, transport, and deployment. As public health response planners, we need this information in real time. We have to know where it is, what condition it's in, who has it. And to be effective, we need all this information in real time, like the Game of Thrones. So recognizing the need for an inventory management system, a coalition of 34 communities in Massachusetts approached me and said, Justin, can you take care of this inventory management issue? Here's $40,000. You have 4 months before the end of the grant year. The message I received was, we have a problem. We need a solution fast. I jumped at it. Very rarely do you get that sort of flexibility in government. And also, given very little direction, I saw it as an opportunity to innovate the way I wanted to. So I began by asking myself, should I buy a product off the shelf or go and develop one? I am not a software developer. I know no coding. So there are some advantages to buying off the shelf. However, most of them are really expensive and they require annual licensing that we just can't afford. So we went with a fully customized product based on our needs. So recognizing that we were going to encounter some barriers, I tend to have this mentality of over, under, or through. I tend to ignore stop signs. So when you're going to encounter stop signs in this sort of project, you're going to have human stop signs, you're going to have resource stop signs, you're going to have staff stop signs, but it's important to keep a simple plan while moving forward. And it's also really important to think that simplicity is not simple. You have to constantly evaluate your simple plan and extract what is not necessary or fundamental to your project. Also important is to keep a WWMD mentality, and that stands for what would MacGyver do? So, basically that is make what you have count. You have plenty of resources around you. They're not all funding, but you have high energy people, you have tools around you that you should focus on. Next, I had the benefit of being an end user. I am a public health planner. I have the problem. So I understood what I needed to build a system for. In other projects, you may not understand the problem in its entirety, so don't investigate what the users want constantly throughout your project. Can you have a benefit to limited resources? I think you can. It made me be more frugal in the development. It actually forced me to consider partnerships that I wouldn't have considered otherwise if I had hundreds of thousands of dollars. So it actually can be a benefit to have limited resources. However, when you have limited resources, it's important to not shoot for the moon when you just need to get into orbit. So you have to constantly evaluate what is essential to your product and stay on task. In public health, we often have many, many hats. So I think everyone in this crowd could actually do a project management process similar to this. You're used to having IT problems, project management problems, budgeting problems. You're used to it. And I found that when I was doing that, I could embrace my hats. Juggling competing demands, that's nothing new to everyone in this room. You're going to be constantly pulled in every direction based on your objectives, your budget, your staff, and time to complete the objective. Important to this project for me was sustainability. I'm young in the career. I may not be there in 6 months. I may not be there in a year. So I wanted to make sure that the product that I was working on was going to be sustainable, both financially and there was a continuity of administration. So we've been working on a way to make it that I'm not fully, if I'm not there, I'm not the only one who knows how to use it. Also important was scalability. I built it for a local coalition. However, I kept in mind that there may be a nationwide application for this. So all we have to do is just turn up the bandwidth, and it can be applied to any number of states throughout the nation for low cost. So, and also you have to keep in mind that milk will spill. Issues will come up. I can't anticipate every single thing I'm going to need for a product. So understanding that, I tried to accept that there was a mistake, move on, avoid doing it again, and just keep on plugging forward. Also recognize that you will never be done beta testing. Every time I brought someone in, they have found a bug that I missed after spending countless hours trying to find it. Understand that, accept it, and just keep moving on. Embracing feedback through the beta test. You will constantly hear comments about what you should have done better or what they actually could suggest for improvements. Accept it. It's actually, once I launched this into a beta test and a pilot within another region, I had more suggestions come in that were better than I had come up with. So the takeaway message here is be available, be resourceful, and be innovative. Sometimes when you don't have the necessary resources, you can really get creative, and you can find ways of doing things in a different way for old tasks. Thank you.
Thank you, Justin. That was great. Really great. And I think we're all learning. Are we learning? Yes? Okay. Are we feeling with the moment as if this were a Tuesday night? Okay. So next up we have, one moment. We have Ray Veroshansky, who is, sorry, I have to do quite some, who's the Chief of Public Health Emergency Preparedness at Prince George's County in Maryland. The Prince George's County Health Department presenting what goes on behind closed pods.
Good morning, everyone. So we all work in public health emergency preparedness. We are used to challenges. These challenges can be big, they can be small, they can be in your health department, they can be outside. One of my biggest challenges when I got my job, which is in Prince George's County, Maryland, the National Capital Region, otherwise known as Anthrax Alley, was trying to figure out how to mass dispense to a population of about 1 million. Let me make it clear. Right away I knew one of my challenges was I didn't have the capacity. I needed to reach out, and I needed to reach out to some of my partners. These were closed pod partners. I need this slide up there to make it very clear to you that I couldn't do anything without significant buy-in from my health department leadership. So I approached them with my idea, with my vision, Thank goodness they embraced it. So one of the first moves we made after that is we figured out right away that the brass ring of public health emergency preparedness is mass dispensing. So although I use partners for a lot of things, one of the things I needed to make very clear was that that pod, that setup, is going to be what I need them to do. I had to investigate. I had to look around my county and say, what's out there? And you all probably need to do the same thing. Look in your county, state, wherever you are, region, and say, what's out there? What can I possibly use to help me do my job? In this case, to mass dispense. That's actually a picture of Andrews Air Force Base. Don't look too long. There's a guy in a black van who will take down your name and social security number. And that was one of our first closed pod partners. They're big, and they're in Prince George's County, and they wanted to partner with us. We also looked at things that I had never heard of before called a mega church. I don't know if anyone's heard of that. I'm from New Jersey. We don't have those. But they do have them in Prince George's County, and we did need to embrace those partnerships to dispense. So closed pod partners, military bases, we have faith-based organizations, and we have some universities and colleges. Reaching out to them was exceptional. This is the University of Maryland in College Park. They serve a population of about 34,000. That's pretty big. It'll take a chunk of things off of my plate, and isn't that the goal? Also, some municipalities. There were at least 3 or 4 certain distinct municipalities that approached us and said, we want to be involved, which actually made it a little easier because we didn't have to approach them. So for our closed pods, we allowed municipalities also to dispense. And we also had federal entities. When we went to certain entities, like NASA Goddard and the IRS, they understood what we were trying to accomplish. Federal entities can be your best friends, but work slowly with them, okay? They want to be explained. One of the first steps we did with all of them, we had meetings, okay? And all we did was explain to them the closed pod process, what was going to be entailed, what they were going to have to do. But let me make it very clear, like I said before, they each have certain capabilities. They each have certain things that they can do well, and they each needed to have buy-in. When we went to NASA Goddard, they have a medical director there and a full medical team. That made things easy. Clearly, some municipalities and other places wouldn't have that, and therefore they wouldn't have the same buy-in. But we couldn't go anywhere without first having an MOU. And that's one of the big hurdles, because that really separates things. If you're very serious and very interested in being a close pod partner and helping us with mass dispensing, then we'll get the MOU from you. Once we got an MOU, one of the things that we tried to do was make sure that every single one of these entities had some sort of emergency plan with a mass dispensing element. And that meant more work for us on some level. Let me make it clear, because we had to look at those and make sure they were realistic. We had to look at those and make sure they fit with what we do. After we looked at their plans, we always train with our closed pod partners. So whether it's tabletops, or even allowing them to sit in on other exercises, or functional or full-scale exercises, we try to make sure they know they're part of our team. Okay? 11%. We went from 0% to 11% of our population covered by our closed pod partners in about 1.5 to 2 years. Don't get me wrong, we're not satisfied with 11%, but for a 2-year investment, I would say I'm pretty happy about it. It's about relationships. You're going to be hearing that from people today. You've heard about it already and hear about it later. But I will tell you that our closed pod partners are not just about closed pods. They help us with flu vaccination campaigns, and they help us with other public health preparedness initiatives. And it's great. So what does the future hold for us in regard to Prince George's County? Well, I'll tell you, we want to keep up with the exercises and training and drills, and we want to keep up with the people we have already. But one of the other things we really need to focus on is the joke I made about 2.5 minutes ago about the mega churches. They are huge, and we haven't even begun to tap into that exceptional resource that they are. They've been great. The churches that we've already brought on board have been exceptional, but we need to expand that effort, and that will probably put us at about 20% of our population covered. Okay? So when we talk about what happens behind closed pods, I've tried to give you a brief overview of everything we've done, but I'd like to end by saying the effort's never really over. This is constant and ongoing. One of the things that we're trying to do is make sure that we take care of people during a massive public health emergency. We're going to need assistance with that. It keeps going. Thank you all very much. Have a great day.
Thank you so much, Ray. That was great. I wasn't sure if that was going to be a comedy routine or a stunt speech. And it went very well. We did a rehearsal last night, and it was fun. So next up we have Phil Maytubby, who is the Chief of Public Health Protection for Oklahoma City. and he is presenting on the surveillance behind SNS. Here's Phil.
All right, I must confess something. 20 slides, 5 minutes, Oklahoma accent, not working. So, actually, we did our presentations last night. Figured out my presentation was very technical. I redesigned it last night. So, what I really want you to do is pay attention to what I say. The slides are good background information, and it all applies to what I'm going to say, but it may not necessarily be in the same order as what I'm going to do. So, with that being said, we'll start out. This presentation is really only 3 key concepts that I want you to come away with this. What is syndromic surveillance? Why should you be running it? And how do you run it? You probably never heard a definition this short. What is syndromic surveillance? It's near real-time, pre-diagnosis data that's de-identified, HIPAA compliant, run through algorithms that identify syndromes and subsyndromes. Have you ever heard one that close? Okay. All right, why should you be running? There's several reasons. One is to build community partnerships. You can't go through this process without building those type of relationships that you have with your medical facilities. Another is to build community disease profiles. You need those at all times, like when you're trying to do wellness initiatives or things like that. You need to focus your emphasis on where it needs to go. There's also meaningful use implications. Most of you know that there's fiscal issues that you can actually get reimbursed as a hospital for trying to hit these meaningful use concepts. The syndromic surveillance is one of them. The other is Public Health Emergency Preparedness. That capability 13 specifically mentions syndromic surveillance, and actually some of the surveillance components link up with other PEP capabilities. Now, what does it take? Well, number one reason, I almost left it off, is for early detection, to reduce mortality and morbidity. Depending on what happens, our syndromic surveillance system has alarmed several times. It alarmed during H1N1, so we actually were picking it up. But depending upon the situation that you're in, it could save lives. That's where the SNS kind of linkage is for syndromic surveillance. We're hoping that we can pick up something quickly enough, because you know the timing for lab testing and things takes some time. Sometimes you don't have that time, so we're hoping to get ahead of it. What does it take to run a syndromic surveillance system? Basically, it's boiled down to this: one epidemiologist, IT support, and a health department liaison, and a hospital liaison. That's what it takes. It's 4 people. Now, occasionally you're going to need tech support, and you're going to need advisement from subject matter experts. You already have a great place for that here through the APC program. We work extensively with Tarrant County. They're very easy to work with. You're probably sitting here thinking, well, Phil, trying to reduce budget, why are you trying to get us to do something when we're already losing people? Well, you're really going to have to use the concept of scale. You may not have everybody in your health department. You might have an epi. The health department next to you may have an IT specialist. Join up, make a system. Those people that you have, those 4 people, you can run a whole state syndromic surveillance program out of that. My epi takes about less than an hour every day to do the analysis on our syndromic surveillance program. So it's really not intrusive on the times of your epis. There's some other things that have developed here recently. BioSense and Essence are both going to be available on the cloud now. When everybody started syndromic surveillance, they spent hundreds of thousands of dollars trying to do the implementation and writing of the programs. That's now either low or no cost available on the cloud. In conclusion, I'd just like for you guys to pick up just those 3 items. What it is, I think everybody gets that. Why you should run it. Emphasis number 1 is reducing morbidity and mortality and getting that early look. And then that it is possible no matter what the situation is that you have. Because you may not be able to do it yourself, but you can do it with your partners. So don't not look into that, because there's really no reason not to now. most of the big costs are gone. If you're using existing personnel, it works out very well. All of these people we worked with, very easy to work with. Feel free to hit them up and we can take it after we get through. Hope that was quick enough.